Disruption, if it's in the right hands of people who want to make healthcare better, can really be transformative. You would think national policy is at scale, but it doesn't get you direct impact where you're actually making healthcare different for people who really need it. Figure out how to lower costs in healthcare, which is hard, and do it in a way that either maintains or increases quality. The potential for consumer-facing apps is really transformative. How do we equip providers with real-time data? We spend twice as much as other westernized countries, and I can't say that we get better health outcomes as a country for it. That doesn't have to be the case.
I thought I would just start by asking you, you've had an incredibly diverse career. You've done everything from being a frontline provider in a labor and delivery unit to working in the Senate to, lobbying to being a consultant at McKinsey, leading teams. What made you take this role? And tell us more about that role.
I get bored easily. And so I feel like I'm changing it up every few years where there's a new adventure opportunity that comes. As you said, I've started my career as a labor and delivery nurse. Actually, before that, informally, I grew up doing medical mission trips to Mexico with my family. And every Christmas, we would ship down to Mexico. My dad's a trauma surgeon. We would actually help set up a hospital and run it for a week. And I just saw that the power that healthcare has to change lives when you're meeting people where they're at and solving a real physical or mental health kind of a need. And that really was the start to my whole career, which is how do we change healthcare for the better so it's actually changing people's lives and giving them hope and ability to live their lives. And so started out as a labor and delivery nurse. My parents were actually in Washington, D.C. when I was in college. And so I would come home to D.C. on summer breaks and had friends that were doing interns on Capitol Hill. And I was like, well, that sounds really interesting. Why don't I go do a policy thing? Yeah, exactly. And then I sort of got the political bug. And my dad, as a physician, was like, why don't you finish your nursing degree? Like, we paid for 3 years of it. Please just finish and get the degree, which was great advice. I picked Georgetown literally because it was in D.C. because I wanted to go into policy.
Right.
I kept my promise to my dad, did the fellowship. And then I was like, yeah, I still have the bug. I want to go into policy. And so that led to conversations in the Senate. I got a chance to intern on the Health, Education, Labor, and Pensions Committee, led to a full-time job. And then 10 years later, it was kind of time for the next challenge. I'd picked up an MBA along the way because for me, I wanted to go make change on the private sector side.
At some scale.
At scale, exactly. And it's interesting way to say it because you would think national policy is at scale, but it doesn't get you direct impact where you're actually making healthcare different for people who really need it. So I had a mentor
it lays down the railroad tracks, though.
Yes.
So
yeah, 100%.
Sometimes trains can go.
Very true. But the scale, you're right. I think just happens. Building businesses and helping them perform better. So I had a mentor that had been at McKinsey, and I was like, "Oh, what's McKinsey?" I was a nursing major. We didn't know, business consulting.
I said the same thing before I went to McKinsey. What is this organization?
But 10 years later, after McKinsey, I loved it. I did not plan to stay as long as I did, but the people are incredible, and it teaches you, as you know, a different way to solve problems. And I think we get a little bit egotistical, but we can solve any problem. But it takes away the fear that status quo can't be changed because you think you can go in and really tackle hard problems and solve them. So I'd been doing that for 10 years, and then Dr. Oz called in November, right after the president nominated him to be administrator for CMS. And he's like, hey, I know we haven't met before, but what would you think about coming to CMS with me? And this is so classic Dr. Oz. I said, well, can I have a couple weeks to think about it? I'll be with family, over Thanksgiving. He's like, how about 24 hours? Because I need to get my chief of staff's name to the White House tomorrow. I was like, okay, I see how this is going to be.
The train is leaving.
The train is leaving.
Yeah.
But it's a good, story about how life has really been at CMS, to get to your other question. Which is, we came in because we want to make a difference. We all took massive pay cuts to come into government, but we really believe we've got the right team and the right mission to really make a big difference. And so I took this job because I was like, okay, this Dr. Oz guy, he's had a show. He's an incredible communicator. You think about the complexity of healthcare, and people are scared when they don't understand change in healthcare. And you've got this master communicator that's empowered by the president to do really bold things. Sometimes disruption, there's been a lot of that the last 9 months, but that disruption, if it's in the right hands of people who want to make healthcare better, can really be transformative.
So one of the things that, you learn in the private sector, I think probably both of us saw in spades at McKinsey at the firm is team matters. Great teams can do really great things that might not have been possible otherwise. And so tell us a little bit about the team that exists today at CMS, the team that you've had an opportunity to continue working with, and the team that you're building, over the course of this year and coming months.
That's a great question. It's fun coming from you too. I've talked to so many founders who you've mentored, and they've said, she understands talent and how do you make life sustainable so people can actually build companies that last. And we really tried to keep talent in mind. So I told you Dr. Oz called me in November. We spent all of December. I think I got a day and a half off for Christmas and maybe a day for New Year's.
Thank you for your service.
But thinking about building the team. The other thing that we did is spend a whole lot of time on strategy, which I'll come back to. But as far as building the team, obviously we needed people who understood policy and pitfalls and lessons learned from things that have been tried in the past. But we wanted people from business, startup founders, folks, consultants that had been in the real world and just built things. And so if you look at each of our major centers, we have that except for one. If you've got ideas on marketplace entrepreneurs that want to come into government, let me know. But a good example is our Medicare team, where we have Chris Klump, who has become a dear friend, is a very successful founder, spent time in the VC world, and he comes in as like, how can we change this and disrupt and build back better in a way that really improves seniors' lives? So he's kind of our instigator and is our leader, but he's supported by a principal deputy who's been on Capitol Hill, his first Trump administration, knows government inside and out, and then, two other folks that know policy well. And that team is just dynamite. I mean, just the kinds of things that are taking on and the change that you're driving is really inspiring. We've got our new head of Medicaid is coming in, also an entrepreneur that founded a successful company, knows the Medicaid space really well from work with his company, but then we'll have a principal deputy who's a former Medicaid director. And so just that powerful combination, I think,
so
has
a
been
lot of
inspiring
real
for
world
us.
experience,
Yes.
a lot of execution experience, operational experience,
Yes.
team building experience. You have this experience too from your time at McKinsey and on Capitol Hill, but a lot of people who have experience interfacing with large incumbent organizations, the institutions that keep our healthcare system alive.
Mm-hmm.
You all know how to work with that group pragmatically. That kind of seems like a fair kind of observation from the outside, which is very exciting for folks who are trying to innovate. The startup world and the innovation world has the moniker, move fast and break things. But sometimes, healthcare might be one of those things, or maybe we don't want to break things. So how do you guys balance the move fast and try things and don't fear failure? But also healthcare is a safety net. You've worked on an L&D floor. We can't compromise the frontline healthcare infrastructure that we have. And we don't want it to break, really, kind of ever. It's almost like we have zero tolerance for breakage at some level, even though we want to move things. So how do you guys think about that?
Yeah, that's a really good question. And one we've really tried to hit the balance on, and bringing in the fresh eyes with the old hands that know government, I think has been part of that. The other part is we've had really big challenges we've tackled, and I'll give you two examples. We've tried to keep that principle in mind. So, DOGE obviously was a big part of the first 6 months of this administration and challenged every single agency to do things differently. Do we have the right approach to contractors, the right approach to people? Are we saving money and being good stewards the way that we should be? And by the way, on DOGE, we said we will understand your questions and we want to run with this and shape what the outcome is. And so they actually let us do that. So our CMS outcome was a little different than a lot of other agencies. But when we did that, some of the things, when there were some rifts that happened, we did not touch the entire Medicare team. We did not touch the entire Medicaid team because we wanted to make sure that there were no disruptions in the provision of those benefits and nothing breaking. As we've tackled some of the tech pieces of CMS, so our Medicare, systems are very, very old. and some of them still literally running on COBOL, which is insane. You think about the fragility of that system and how sensitive the data is. But as we've thought about that, we're not going to touch that until we have a solution alternative over the long term that we know will work, and so we won't disrupt things. So I think that's one place. Another big place is as we were working with Capitol Hill on One Big Beautiful Bill, we did not touch benefits. We did not want to take any benefits away from current Medicaid beneficiaries. There's some things that we did that shifted financing. So there was maybe a rebalancing of federal and state financing commitments, but we didn't touch benefits. And that was very important to us. And it was important to the president. I think maybe those are two examples that illustrate.
Of where you preserved.
Yeah.
So maybe that's a good segue into, I just wanted to ask you to share like a couple quick, fast examples for listeners on what are some big principles of how payment, reimbursement, recognition of value, measurement of quality, CMS over the last many years, CMS and CMMI made great strides too in making healthcare work better and making payment more aligned to health outcomes. What are some examples of initiatives, whether they're alternative payment programs, value-based care programs, specialty-specific programs like the kidney care program?
Yep.
What are some examples where, if you could share, where actually you perceive there to be a commitment to continuity and where you say, hey, we're going to double down on something that we saw work and we're going to create that visibility for innovators to continue to get better and improve on something that will be stable.
Yeah.
And then I'm going to ask you the same question around something that's changed, that you're moving in a more dramatic way.
Yeah. I think the best place to illustrate this is probably within our innovation center. And the mission of the Innovation Center was enacted right in Obamacare as a core part of it. And the mission was to do two things: figure out how to lower costs in healthcare, which is hard, and to do it in a way that either maintains or increases quality. And so we took that statutory lens and then we built our strategy. Liz Fowler is a good friend. We worked together in the Senate ages ago. And she did a lot of work trying to move towards accountable care and really set a vision for every Medicare beneficiary being in an accountable care relationship by 2030. And there's a lot of that aspiration we agree with. We've retooled it. Every administration has to go through their own process, but really tried to articulate three things. One, we want a greater emphasis on prevention and chronic disease management. That aligns with the Secretary's Make America Healthy Again agenda, which at its core is about prevention and how do we take better care of our bodies so we can do the things we want to do as humans. So that was principle number one. Another part of that was giving individuals more agency over their own health and helping empower them. There's a lot of our technology agenda that really plays into that when the potential for consumer-facing apps is really transformative. And then a third part is more choice and competition in the kinds of innovators and companies that are helping us achieve that statutory mission, if you will. And so there's some of those things where we went through all of the models that were existing early in the year, looked at what's on track to lower costs. That's our job from Congress. And said, there's some of them we're an innovation center. We're supposed to test. And we figured out this isn't on track to save money to the system. And that's okay. We're going to move on. But there were many that were like, actually, this has a lot of promise. Maybe there's some tweaks that we need to make. One of the models on maternal health, another model on mental health. Those are things that are sticking around. We're working with states to make sure it's working the way they should be. But those are models and principles we are absolutely still working on and believe are still consistent with our mission.
And what's an example of where the rubber meets the road on, what sounds like a high-level policy, empower consumers, incentivize prevention, get the system to kind of join forces in making America healthy again? What's an example of where the rubber meets the road and CMS could come in and say, hey, here's the lever, here's the policy lever that aligns to that prevention prioritization agenda? Like, is there a specific example that comes to mind for you?
There's probably two examples. One that you would have intuitively thought of, which is how do we get the clinicians that are part of various accountable care models to think more about it and incentivize them to do those things. And I think a lot of those models focus on kind of the very near term, but sometimes not the fundamental building blocks of primary prevention, or just healthy lifestyle choices around physical activity and nutrition. So greater emphasis there on existing models. But I think
Does that take the
technology,
form of quality bonuses?
it could, yeah.
What do you think is coming down the line for people who are trying to build? Is it going to be, hey, if you're building a value-based care model, be thinking about a slightly different and evolved set of quality measures?
Yeah. Let me give you
Is
examples.
that too narrow thinking?
No, it's great. Some of the things we are asking questions about, I don't want to give you the impression we have made decisions on them yet, but things we've asked about, like how do you help somebody improve their VO2 max fitness scores? Like that's a very measurable thing that gets into fundamental lifestyle
And who
choices.
get paid for doing that?
In some models, you could think about the clinician that's doing the right counseling to encourage people to go out and do this and get on a walking plan where there's measurable improvement over 12 weeks. You could imagine a quality score that gives credit for that.
Totally. So new quality measures that we haven't seen before.
Yes.
That are fundamentally aligned to improving overall health, and even though the disease implications might be years out.
Yes.
But recognizing that that's an early indicator, it's an early signal that we should get ahead of. Okay, super interesting.
I think another one is, coming back to this theme of technology, and I would say this is Dr. Oz's number one priority, which is how do we use technology to empower consumers with consumer-facing apps? And like, there's a lot of tons of uses of technology, but the consumer-facing piece, if we can really unlock that, I think it's transformative and our priority. And to the extent you can, and there's some companies that have already figured out how to do this, where you can connect somebody's medical set of medical records with a generative AI engine that can go and say, okay, you've got a family history of this, or look, we're seeing some uptick in your BMI, or whatever it might be, and give people that information, and then figure out what are ways that we can drive behavior change, and some of that you can measure via engagement with an app, not just signing up and downloading one, but engagement with an app. That's an early indicator, but longer term, how is it translating to some of those foundational lifestyle changes?
So maybe a national personal health record, maybe it's sort of take advantage of the health information exchange infrastructure that we've already set up to roll out direct consumer access to that data, along with sort of what we'd call in the AI world promptless advice and interpretation of that data.
Yeah, there's engagement. And I think you hit on a couple of things that are good to clarify. We don't want the government to own health records. Obviously, we have Medicare claims data already. But we do think these federated data systems where you can use interoperability so that ultimately the consumer, if they want to, can very quickly access their medical records from across different systems and not have 30 different logins that they have to do. That just makes it so tedious. A lot of people just don't do it. But that's a technological problem that we've really spent a lot of time on thinking about how to unlock with entrepreneurs. We did an event at the White House end of July, about 60 different tech companies, and then I would say tech forward payers and providers that are committed to this. And it's all about really unlocking that for the consumer so they can access their medical records and then feed an app ecosystem where those kinds of solutions are available to consumers. We don't want to say this is the only one. We're not tech entrepreneurs in government. We've got some in government that are changing, but we want to empower the private sector to create those. And we've outlined a few use cases where we think there's a lot of promise.
And there might be a marketplace.
And there could be a marketplace. And we've got access to, in our Medicare open enrollment season, more than 60 million beneficiaries. That's a market access opportunity that we do have some input and control over. And I think longer term, we are absolutely looking at what are appropriate ways to reimburse on this. There's some things that ARPA-H has already made available very early in the pipeline. I think more on that, to come in the future, but then some longer term incentives that we could actually give some credit when we believe it's at the right set of safety and quality standards.
Super interesting. And so it might be a provider, it might not be. It could be a technology innovator that accesses a CMS reimbursement rail, maybe one that hasn't existed before, but one that fundamentally empowers patients to improve their health. Super interesting. Well, we've already started talking about it, but I just wanted to kind of push your push you to also share a couple examples of where you think CMS might be taking kind of a hard left. Like, what's an example of something where you said, hey, this was the old way, and we're just bringing a different paradigm to it altogether. And we want innovators to know that this is changing.
Yeah. This is one that's gotten some attention, and I will bring it up because I want to address and clarify some of the feedback that we've gotten. We sent out some letters early this year saying that in Medicaid innovation waivers, we call them all 15 waivers, that we're not going to cover health-related social needs as part of renewals. We were like, if it's in place, that's a different thing, but moving forward. And the reason we did that is because we don't think CMS as a healthcare regulator and payer is very good at figuring out how do you pay for education or housing or air conditioning assistance. And there are actually other federal agencies whose job is to do that. And we think they're just going to do a better job administering those programs. And we wanted to focus Medicaid on healthcare services directly. And the reason I want to clarify it is it's not, we've seen the data. Like there's absolutely a role for some of those broader things in improving the lives of human beings. But it's thinking about what's the right role for Medicaid. And then also thinking about what's the opportunity for entrepreneurs to coordinate other resources from federal and state governments that actually might be better.
Navigator,
or private sector
navigator.
Absolutely. And so that's something where we've said, hey, we're not going to do that, but it's not because we don't think it's important. It's just more, we're not good at it.
Yeah, you mentioned marketplaces at the beginning, but that's a great example. These are hyper-local marketplaces.
Yes.
These marketplaces for non-medical services have a lot of similarity in some ways to to a large other group of vendors, whether it's, local restaurants, there's a lot of private sector activity and experience that's gone into curating, accessing, paying for, finding, monitoring, checking availability, and ultimately connecting a consumer or a patient to one of these services. That's actually a really inspiring vision and makes a lot of sense from an efficiency perspective. But you're still thinking there may still be reimbursement dollars available
through other
resourcing.
Yes. And so the challenge, for innovators is like how to use the right set of resources to marshal those to get the right answer for individuals.
We've talked about how this year has been incredibly busy, or rather, I should say, the holiday leading into this year. Building a team, continuing to work with some really great folks who've already been at CMS for many years. Rolling out some new policy arenas, but also doubling down on policy and payment rails that you think have worked. What should we expect from CMS over the next 3 years?
Yeah, we so I mentioned we spent December and January on talent and strategy. I'm a classic McKinsey person, as you know how that goes. And we actually went through a rigorous strategic planning process. We used the OKR framework, or Objectives and Key Results framework.
We love that.
We love that for you. You preach it. And imagine doing that in government where we spend that much money. And so we did a retreat for those that had already been hired right before we all got sworn in, January 20th. So this is like the weekend before. And we went through as a team talking through those. Then I started, Dr. Oz came in April, and then we formalized that discussion into very clear set of OKRs. So I could tell you, we have 5. Each of those 5 has a subset, very
googly
specific. Yeah, exactly. But the first one is we wanted to be the leading payer. There's parts of that. We went through a rigorous exercise with Doge to make sure we were being good stewards. Another part of that is we want to be a talent magnet. Any successful organization has got the talent thing figured out, and we have an incredible set of career staff. We also, from talking to them, we also want to bring in folks who may not have thought about government as a career destination, but they might come in for 2 to 4 years. I call it the Teach for America model, where you get just folks that, I'll come in and serve my country for 2 years. And then we tap into different types of talent for that. And that's really important for our tech agenda. So I'd say that first one is all about being the leading payer.
We've had amazing experiences across our own portfolio with startups in the private sector. People who have that experience, as you know well personally, bring a lot back to the private sector when they join companies who then build, you know, in alignment with certain really transformative policy rails. And so I think that's amazing. Speaking for myself and companies that I have an opportunity to work with, we think that type of talent, you know, would be incredible coming
send them our
coming
way.
back out of DC. Yeah,
Yes.
we'll send them your way so that we can hopefully have a chance to work with them on the other side too.
I'd love it. Second one is going after fraud, waste, and abuse. In a $1.7 trillion program, you can imagine there's a lot of it. The third one is around the consumer-facing technology piece that we talked about earlier. The fourth is also a tech theme, which is how do we equip providers with real-time data? You think about a lot of our quality metrics, a care or service happens and they don't get a reward till 18 to 24 months later. That's not a great way to drive behavior changes.
Mhm.
You think about it, but
It's also a tough way to build a private sector business.
Yes, exactly. As you know, so that's the fourth one is like how do we update all of our payment systems to real time? There's quality, obviously, systems that align with that. The fifth is around better aligning spending and value. You know the data very well. We spend twice as much as other westernized countries, and I can't say that we get better health outcomes as a country for it. And that doesn't have to be the case. And so there's opportunities really across all of our programs to take that lens and just be better stewards.
It's amazing. CMS has OKRs, and you guys are holding your teams accountable and excited and energized to execute against those OKRs. I think that's great news. Most importantly for American patients, but also for all the organizations that are really hoping to partner with you and your team deeply. So thank you.
Yeah, thanks. Thanks for having me.